why your chronic pain never ends, and what science says to do instead. I want to ask you something that your doctor has probably never asked you directly. When you reach for the ibuprofen, the acetaminophen, the naproxen, do you ever wonder why the pain keeps coming back? Not why it exists in the first place. Why, despite years of managing it, it has not resolved. Why the medication provides 4 hours of relief and then the pain returns, often slightly worse than before. Why the problem never actually gets smaller. The answer is not a mystery. It is biology. And it is biology that the standard approach to chronic pain after 50 is almost entirely failing to address. Here is what the research now shows clearly. Chronic pain in adults over 50, whether it is joint pain, back pain, neuropathic pain, or the general aching heaviness that many people describe as their body just feeling old, is not primarily a structural problem. It is not simply the mechanical consequence of worn cartilage or aging discs, though those changes are real. It is fundamentally an inflammatory and neurological problem. It is driven by the same systemic inflammation we discussed in our inflammation episode, amplified by a phenomenon researchers call central sensitization, a state in which the nervous system itself becomes chronically overactivated and begins generating and amplifying pain signals independently of the original tissue damage. Understanding that distinction between the tissue problem and the neurological and inflammatory problem is the single most important shift in perspective I can offer you today. Because once you understand it, the interventions that actually work become obvious, and the interventions that merely manage symptoms without addressing the root become obvious too. We will dive into all of that in today's episode. I am Dr. Alexander Wellrich. Chronic pain is the most common reason adults over 50 seek medical care in the United States. The CDC estimates that more than 50 million American adults experience chronic pain, and that adults over 45 account for the majority of that burden. It is also one of the leading drivers of opioid dependence, disability, reduced mobility, depression, and social withdrawal in older adults, a cascade of consequences that begins with undertreated root causes and ends in dramatically diminished quality of life. In 30 years of clinical practice, I have watched the standard pain management approach, NSAIDs, muscle relaxants, injections, and when those fail, opioids, cycle patients through temporary relief without ever addressing the biological environment producing the pain. The inflammation remains. The central sensitization deepens. The medication requirements increase. The quality of life continues to decline. What I want to offer today is a different framework, one grounded in the emerging science of pain biology, and one that points toward interventions that genuinely address the mechanisms rather than simply suppressing the signal. Not a promise of complete resolution, but a meaningful, evidence-based path toward less pain, better function, and a biology that is working with you rather than against you. If this kind of honest, root cause conversation is valuable to you, please subscribe to this channel. And now, let us talk about what chronic pain after 50 actually is, and what you can do about it at the level that matters. Let me build the scientific foundation, because without it, everything else will feel like generic lifestyle advice, rather than the targeted biological intervention it actually is. Acute pain is a protective signal. You touch a hot surface, pain receptors called nociceptors fire, your nervous system registers the signal, and you withdraw your hand. The signal is proportionate, appropriate, and temporary. It serves a clear biological function. Chronic pain is a fundamentally different phenomenon. A study published in the journal Science defined chronic pain as pain that persists beyond the expected healing time for a given tissue injury, and found that the transition from acute to chronic pain involves measurable structural and functional changes in the nervous system itself. The brain and spinal cord literally reorganize around the pain experience, lowering the threshold at which pain signals are generated and amplifying the signals that do occur. This process, Central sensitization has been documented by functional MRI studies showing that people with chronic pain have measurably different patterns of brain activation compared to pain-free individuals. The areas governing attention, emotion, and memory become entangled with pain processing in ways that explain why chronic pain is always worse when someone is stressed, sleep-deprived, or emotionally depleted. The nervous system is not malfunctioning randomly. It is responding to a sustained biological environment of inflammation, oxidative stress, and neurological overload. Inflammation is the primary driver. The same inflammatory cytokines, interleukin-1 beta, interleukin-6, tumor necrosis factor alpha, that we discussed in our cardiovascular and inflammation episodes, directly sensitize nociceptors, lower pain thresholds, and promote central sensitization. A study published in Pain, the leading journal in the field, found that blood levels of inflammatory markers were significantly correlated with pain intensity and disability in adults with chronic musculoskeletal pain. This means that reducing systemic inflammation is not a peripheral strategy for chronic pain. It is a direct intervention at the biological mechanism producing it. Mitochondrial dysfunction, our first episode, also connects here. Neurons are extraordinarily energy-demanding. When mitochondrial function is impaired, neurons become more excitable and less capable of regulating their own firing thresholds. A study published in the European Journal of Pain found that mitochondrial dysfunction in peripheral nerve cells was a significant contributor to neuropathic pain states. Supporting mitochondrial health is simultaneously supporting pain regulation. And sleep, as we discussed in episode 6, completes the circle. Sleep deprivation lowers pain thresholds, elevates inflammatory markers, and promotes the central sensitization that transforms manageable discomfort into debilitating chronic pain. A study published in Sleep found that even one night of disrupted sleep significantly increased pain sensitivity the following day. The biology of pain, inflammation, sleep, and mitochondrial function are not separate problems. They are one system. I want to be direct with you about something because this is important and it is not being said loudly enough in mainstream medicine. The most commonly used medications for chronic pain in adults over 50, NSAIDs like ibuprofen and naproxen, are not benign long-term tools. A study published in the Annals of Internal Medicine found that regular NSAID use in adults over 65 was associated with a 3 to 5 times increased risk of gastrointestinal bleeding, a significant increase in cardiovascular events, and measurable decline in kidney function. NSAIDs work by suppressing the COX enzymes that produce inflammatory prostaglandins. This reduces inflammation and pain in the short term. But it also suppresses the prostaglandins that protect the stomach lining, regulate kidney blood flow, and modulate platelet aggregation. The trade-off is acceptable for short-term acute pain. It is not acceptable as the primary long-term strategy for a chronic biological condition. Opioid medications suppress pain signals effectively in the short term but produce tolerance, requiring escalating doses for the same effect, and paradoxically promote a phenomenon called opioid-induced hyperalgesia, in which the pain system becomes more sensitive over time with sustained opioid use. A study published in Anesthesiology found that long-term opioid use was associated with measurable increases in pain sensitivity compared to non-users with similar underlying conditions. The medication designed to reduce pain can, with sustained use, increase it. And corticosteroid injections, while providing meaningful short-term relief for conditions like osteoarthritis and tendinopathy, have been shown in research published in JAMA to accelerate cartilage loss with repeated use, potentially worsening the structural problem they are treating over the long term. None of this means these medications have no role. They do, in appropriate clinical contexts and for appropriate durations. What it means is that they are being used as primary, long-term strategies for a biological condition that requires a biological solution, and that substitution is producing harm at scale in the over 50 population. A few years ago, I worked with a patient I will call Barbara. She was 66, a retired librarian from Phoenix, Arizona. She had been living with chronic knee pain and lower back pain for 8 years. Her orthopedic surgeon had told her she was not yet a candidate for knee replacement. She had received 3 cortisone injections over 2 years that provided diminishing relief. She was taking ibuprofen daily and acetaminophen as needed, and she described her pain as a 7 out of 10 on an average day. When we did a comprehensive assessment, the biological picture was clear. Her hs-CRP was 5.8, indicating significant systemic inflammation. Her omega-3 index was 3.2, well below the protective range. Her sleep was severely fragmented, averaging 5 hours of broken rest per night, which was driving inflammatory cytokine elevation and lowering her pain threshold simultaneously. Her vitamin D was deficient at 18 nanograms per milliliter, and she had been sedentary for years, which had accelerated muscle loss around the knee joint, reducing the mechanical support for damaged cartilage while simultaneously deepening her central sensitization through inactivity. Barbara did not have a medication problem. She had a biological environment problem. We addressed the inflammation through dietary changes and targeted supplementation. We rebuilt her sleep using the protocol from episode 6. We initiated a gentle aquatic exercise program to rebuild muscle without loading the damaged joint. Within 4 months, her pain had dropped from a 7 to a 3. Her ibuprofen use had essentially stopped. Her hs-CRP had fallen from 5.8 to 1.9. The biology had changed, and the pain had followed. And here is the evidence-based toolkit for achieving exactly that. The specific dietary, nutritional, and lifestyle interventions that the research supports for reducing chronic pain at its biological roots. Let me give you the specific interventions with the strongest evidence for chronic pain reduction through biological mechanisms. Omega-3 fatty acids from fatty fish or fish oil are among the most well-studied natural anti-inflammatory compounds available. A meta-analysis published in the Clinical Journal of Pain reviewed 18 randomized controlled trials and found that omega-3 supplementation significantly reduced pain intensity and the need for analgesic medication in patients with chronic joint and musculoskeletal pain. The mechanism is direct. EPA and DHA compete with arachidonic acid for the same enzymatic pathways that produce inflammatory prostaglandins, shifting production toward less inflammatory and anti-inflammatory eicosanoids. The studied doses range from 2 to 4 grams of combined EPA and DHA daily. This is meaningful pain biology, not marginal lifestyle support. Curcumin, the active compound in turmeric, has been studied specifically in osteoarthritis, with results that rival NSAIDs in several trials. A systematic review published in the Journal of Medicinal Food analyzed multiple randomized controlled trials comparing curcumin formulations to ibuprofen for knee osteoarthritis and found comparable pain reduction and functional improvement, with dramatically fewer gastrointestinal adverse effects. The critical issue with curcumin is bioavailability. It is poorly absorbed on its own. Formulations with piperine from black pepper, phospholipid complexes, or nanoparticle delivery systems show significantly improved absorption. Doses of 500 to 1,000 milligrams of a bioavailable curcumin formulation daily have been used in the strongest clinical trials. Collagen peptides have moved from the supplement aisle into the clinical literature in recent years with increasingly convincing results. A study published in the British Journal of Sports Medicine found that collagen peptide supplementation, combined with vitamin C before exercise, significantly increased collagen synthesis in connective tissue and reduced joint pain in athletes with joint problems. A separate randomized controlled trial published in Current Medical Research and Opinion found that 10 grams of hydrolyzed collagen daily for 24 weeks significantly improved joint pain, stiffness, and function in adults with osteoarthritis. The mechanism involves providing the amino acid building blocks, particularly glycine, proline, and hydroxyproline, for cartilage matrix repair. Magnesium plays a specific role in pain regulation that is distinct from its general anti-inflammatory effects. Magnesium is a natural antagonist of NMDA receptors, the glutamate receptors that are central to central sensitization. When magnesium levels are adequate, NMDA receptors are partially blocked, reducing the amplification of pain signals in the spinal cord and brain. When magnesium is deficient, which is common in adults over 50, this natural brake on pain amplification is reduced. A study published in Magnesium Research found that oral magnesium supplementation significantly reduced pain scores in patients with chronic low back pain. Magnesium glycinate at 300 to 400 milligrams daily is both well tolerated and well absorbed. Let me now address the lifestyle interventions that work directly on central sensitization, not just inflammation, but the neurological component of chronic pain. Exercise is the intervention with the strongest evidence for central sensitization reversal. It works through a phenomenon called exercise-induced hypoalgesia, the reduction in pain sensitivity that occurs during and after physical activity. Research published in the journal Pain found that regular aerobic exercise significantly reduced central sensitization markers and pain intensity in adults with chronic musculoskeletal conditions, with the greatest effects seen from consistent moderate intensity activity. The mechanism involves the release of endorphins, endocannabinoids, and serotonin, natural analgesic systems that are activated by movement. It also involves anti-inflammatory myokines released from working muscle tissue that reduce the systemic inflammatory load driving peripheral and central sensitization. For people whose pain limits conventional exercise, aquatic exercise and Tai Chi have the strongest evidence for joint pain specifically. A meta-analysis published in Arthritis Care and Research found that Tai Chi significantly reduced pain and improved physical function in adults with knee osteoarthritis, with effect sizes comparable to conventional physical therapy. The combination of gentle load-bearing movement, balance training, and the mind-body component that reduces stress-driven pain amplification makes it particularly well-suited to the pain profile of adults over 50. Sleep restoration is a direct pain intervention. As I noted earlier, sleep deprivation lowers pain thresholds measurably. The reverse is equally true. Improving sleep quality produces measurable reductions in pain sensitivity. A study published in the Journal of Pain found that cognitive behavioral therapy for insomnia, CBTI, which we discussed in our sleep episode, produced significant improvements in chronic pain outcomes independent of its effects on sleep, suggesting that the pain-modulating effects of improved sleep go beyond simply feeling more rested. Every investment in sleep quality is an investment in your pain threshold. Here is your root cause pain protocol. 1. Address your systemic inflammation as the primary intervention. Adopt the dietary anti-inflammatory pattern we discussed in Episode 3. Extra virgin olive oil as your primary fat, fatty fish 3 times per week, abundant, colorful vegetables, berries daily, and dramatic reduction of refined carbohydrates, added sugars, and processed seed oils. Request an HSCRP test to establish your baseline and track your progress. Inflammation reduction is pain reduction. 2. Add omega-3 supplementation at 2 to 3 grams of combined EPA and DHA daily if you are not consistently eating fatty fish. This is one of the most directly evidence-supported nutritional interventions for chronic musculoskeletal pain in the clinical literature. 3. Consider a bioavailable curcumin formulation at 500 to 1,000 milligrams daily as an adjunct to dietary change, in conversation with your physician. If you take blood thinners, discuss this specifically, as curcumin has mild antiplatelet activity. 4. Begin gentle, consistent movement within your current tolerance. Start with 10 minutes of walking, aquatic exercise, or Tai Chi, and build gradually. The goal is not performance. It is activating the endogenous analgesic systems that only movement can switch on. Every day of movement is a day of neurological recalibration. 5. Implement the sleep protocol from episode 6 with the specific understanding that you are treating pain as much as you are treating sleep. Morning light, consistent sleep timing, cool bedroom, magnesium before bed, evening light reduction, caffeine cutoff by noon. 6. Have your vitamin D level checked and optimize it to between 50 and 70 nanograms per milliliter. Multiple studies have linked vitamin D deficiency to heightened pain sensitivity and musculoskeletal pain syndromes. It is inexpensive, safe, and measurably impacts the inflammatory environment driving your pain. Let me bring everything together. Chronic pain after 50 is not the inevitable price of an aging body. It is the biological consequence of a sustained inflammatory environment, supported by mitochondrial dysfunction, sleep disruption, nutritional deficiencies, and a nervous system that has reorganized itself around a pain experience that was never properly addressed at its root. It is real, it is serious, and it is far more addressable than the standard approach of symptom management would suggest. Barbara's pain dropped from a 7 to a 3 without a single new prescription. Not because we performed a miracle, because we changed the biological environment that was generating the pain in the first place. The inflammation came down, the sleep improved, the muscle rebuilt. The nervous system, given a different input, began to recalibrate. Your pain is not a life sentence. It is a biological signal asking for a biological response. Give it one. If today's episode gave you something you can use, please like this video and subscribe to the channel. Leave me a comment. Tell me where your pain is and how long you have been living with it. I read every comment, and your story matters. In our next episode, we are going to talk about something that almost every person over 50 is concerned about, but that almost no one is addressing proactively. Bone density. The silent loss of bone mass that begins in our 40s accelerates at menopause in women and with testosterone decline in men, and that ends, when left unaddressed, in fractures that the research describes as some of the most life-altering events in the second half of life. The science of bone health goes well beyond calcium supplements and is far more actionable than most people know. Until then, take care of yourself from the inside out.